Welcome to a new session, and today we are covering the granulomatous skin diseases, and we are using Weedon's textbook 2021 to cover this topic. Hopefully, by now you are familiar with this chart, and we talked in the past about spongiotic and psoriasiform, and we said those are mainly epidermal reaction patterns, and then dermal epidermal reaction patterns. Those are lichenoid and vesiculobullous. And today and next week we'll cover the dermal major reaction patterns. Those are the granulomatous and vasculopathic. So uh, granulomatous and vasculopathic, because they are dermal reaction patterns, most of these lesions, if not all of them, the epidermis will be involved. If you look into the chapter by Weedon, it is divided into different categories with lots of examples that follow the same pattern. And we'll try first to identify the granulomas, and then we will try to see how we study those diseases. So, what is granuloma? Granuloma is an immune response of the body that, when the body is unable to eliminate the pathogen, it will encapsulate that pathogen into a packaged area in granuloma formation, or in a nested formation, or in a mass like formation. So, in those mass like formation, or those areas, there are three types of cells: the epithelioid histiocytes, the lymphocytes, and the giant cells. So, epithelioid histiocytes are basically immune cells, but they have this epithelial like formation. They look like epithelial cells, however, they are not epithelial cells. So, if you stain them with epithelial markers, you will not find epithelial staining. You have to look for immune markers for immune cells. So the late Dr. Bernie Ackerman defines granulomatous inflammation as more than 50% of inflammation that is consistent of histiocytes and macrophages. So, what are histiocytes? Histiocytes are derived from the mononuclear phagocyte system. This is the reticuloendothelial system, and usually those are the tissue macrophages and or dendritic cells. And usually they are born in the bone marrow, and then they go through their life cycle, and they uh, immigrate to certain body areas, and they enter those organs, and they become macrophages or giant cells under the influence of T helper 1 cells by the effect of interleukin 2 and interferon gamma. Uh, T helper 2 is like the negative feedback that impairs the formation of those granulomas in order for the body to heal from those granulomas. So, if there is like an immune compromisation, or there is like a balance shift between T helper 1 and T helper 2, you will see either more granuloma formation or impaired granuloma formation. If you stain those histiocytes, usually they are immune cells, so they will stain as bone marrow pan cells markers, CD45, also macrophages, CD14, CD33, and T helper cells, CD4, is also identified with variable amounts of lysosomes that help to destroy the pathogens and help the immune system. So there are two ways to study those granulomas. If you read the literature, there is the morphologic way, where it depends on description of how those lesions appear under the microscope, and there is the etiologic way, where it divides them in based on the causative agent for those lesions. So we'll try to cover both kind of systems and try to explore in a simple way uh, how we try to differentiate those granulomas under the microscope. So the first pattern is the sarcoidal pattern, and those are well circumscribed granulomas. They are formed of epithelioid macrophages, and there is no significant inflammation or lymphocytes around those granulomas, and that's why they are called usually naked granulomas. You see them in sarcoid doses and also other diseases. And we will talk a little bit about like how to differentiate sarcoid from other diseases when you see naked granulomas. The other pattern is the less well circumscribed, is the tuberculoid pattern. Usually those granulomas are formed of epithelioid histiocytes surrounded by abundant lymphocyte, and sometimes you see giant cells, horseshoe giant cells, sometimes you see plasma cells, and sometimes also you see the caseating necrosis, or as like our classic teaching when you see basically the difference between sarcoid and TB is one has the necrotizing granuloma and the other non-necrotizing granuloma based on the necrosis. However, in reality, the necrosis is not always a feature of those granulomas unless those like lesion where biopsies in an area where there is necrosis. A third pattern is the suppurative pattern, also less well circumscribed. Like an abscess formation, you see abundant neutrophils with accumulation of macrophages. If you look, for example, into this picture, you see like those tangible body macrophages that they look like if you look before into a follicular center of a lymph node, you will see those like germinal center areas where it looks like an abscess formation. And usually, this is the etiology in those are infections. So you have to do a little bit of further testing to identify the causative agent. The last one is the palisading fashion granulomas, and those we see the collagen bundles as you see here in this picture. All these collagen bundles are undergoing necrosis, and they are usually forming well circumscribed area, not many lymphocytes or inflammation around it. And usually we see other features like increased mucin or maybe other features. We'll talk about it in specific diagnoses. So I made this table I adapted from Weedon's chapter just to show you like the different diseases and the main cell types that we see in all the granuloma formation, along with the cell type, the inflammatory cell type, and if there is like any specific feature. So if you look to compare between all these diseases, you will see like all of them they have epithelioid histiocytes, and all of them they have some sort of giant cells, and all of them they have inflammatory cells that are mainly composed of lymphocytes and sometimes plasma cells, or sometimes like mixed inflammatory infiltrate. So just by looking at this table, it is hard on morphology alone, like looking by histology, to identify those lesions. So we have to do further testing and we have to correlate with the clinical history. And that's why it's important to keep in mind the morphology division and the etiology division. So both we need both systems in order for us to make a correct diagnosis. So, what is the etiology system? Granulomas are divided into infectious and non infectious granulomas. In the infectious categories, we have sarcoidal, tuberculoid, suppurative, and palisading, the same four morphological patterns we talked about earlier. And if you see those and you suspected that there is infectious etiology, you can do further testing for all these different pathogens. Like, for example, for TB, you can do AFP. For leprosy, you can do Phyt. For Leishmania, you can do Gimza. For fungus, you can do GMS or PAS. For syphilis, you can do serum antibodies. Uh, and also, you need PCR or cultures. So, you need extra investigation testing in order for you to make a correct diagnosis. Histology alone will not help you to identify causative agents because most of these lesions you will not be able to see the causative agents for the most part. Like for TB, for example, sometimes you look for an hour under the microscope in order to identify one or two rods of mycobacteria. The classic pathology teaching for those infectious granulomas is you see three signs: the pseudoepitheliomatous hyperplasia, neutrophils, and plasma cells. And if you see those, you think of infectious etiology, and then you go further to order further testing. For the non-infectious etiology, we divide them into two categories: the one that happen with connective tissue degeneration and the one that happen with systemic disorders. The one that happen with connective tissue disorders or connective tissue degeneration, granuloma annulare and necrobiosis lipodica. The one that happen with systemic disorders, necrobiotic xanthogranuloma, interstitial granulomatous dermatitis, rheumatoid nodule, gout, orofacial granulomatosis with Crohn's disease, and sarcoidosis. Borrelia agent is by definition research found that it is involved in granuloma annulare and necrobiosis lipodica and necrobiotic xanthogranuloma. And also propionibacterium is involved with sarcoidosis. So as for now, as far as we know, those only two agents that are involved in non-infectious granulomas, and that's why you see those sarcoid and palisading granulomas are listed in infectious. So there is an overlap between those two categories, and I'm sure like the future we will see more causative agents, more infectious agents involved with other non-infectious granulomas. So this table may change, or we may try to find different ways to understand those different diseases. So we start with cutaneous leishmaniasis, and uh, I chose this as the first start because of the Aleppo boil where I did my medical school. This disease is very common in Middle East, especially in Syria. In On the clinical, you see the scaly erythematous nodule on the back of the foot or like extremity, where areas like exposed to the fly where the infection will happen. If you do a biopsy for these lesions, you will see a granuloma formation. On low power, you may see macrophages, those like pale areas of in the biopsy. And on high power, you will see mixed inflammatory cells composed of lymphocytes, macrophages, or plasma cells. If you go on high magnification, you can identify the organism, the Leishmania, is like those blue, gray granules inside the macrophages where you can do Gimza staining. It can help you with visualizing those organisms. So Leishmania has two cell cycle, one inside the human and one inside the fly. And in the acute phase, we see diffuse lymphocytes, macrophages, and plasma cells. Neutrophils is variable. Sometimes we see it in the upper dermis. And the organism, Leishmania, is different from histoplasmosis because of the capsule. And this is one of the questions that they like to ask on the certification exams, how to differentiate between histoplasma and leishmania is basically by the capsule. The infiltrate usually near the epidermis is where you look for the leishmania to find them. Ginza staining, as we said, is helpful to detect those, and PCR, if you are unable to see those on histology, will help you to identify leishmania. Culture is superior to PCR, but it requires fresh tissue, and cytochrome B PCR is more sensitive and specific than the previous tests. Mycobacteria is gram-positive, acid-fast rod bacteria, but usually is hard to see on gram staining because of the cell wall structure. There are three main groups: the Mycobacterium tuberculosis, the one we are all familiar with, and the one that caused the leprosy, and the atypical mycobacterial group. Uh, the ones that are important for the skin histology is the TCV, or tuberculosis cutis verrucosa, LV, or lupus vulgaris, and SD, or scrofuloderma. So TCV, we rarely see those like nowadays because of improving the healthcare system. But usually it happens on the extremity because of direct TB inoculation. Usually it appears like indurated papules or verrucous plaques. And if you do biopsy for those areas, you need to look hard enough to find the TB organism, or you can do a PCR in order to identify those. For LV, or lupus vulgaris, the unique clinical picture of erythematous plaque on the lateral neck with like those satellite-like lesions with central scarring. If you do biopsy, you will see the granuloma formation with this horseshoe-like giant cells. If it is also available, you can see central necrosis that will help you to think about TB, and you can order further the testing. So it is a chronic progressive form of cutaneous tuberculosis in an individual that has a good response immunity, and the granulomas tends to form like cheese-like materials. And of course, if you think about this disease, you can order AFB staining, or you can order further like testing like PCR. Scrofuloderma happens in children, and usually it's a direct extension from underlying tuberculosis to the skin. Clinically, it appears like abscess formation with caseating necrosis, and on biopsy, you can see the macrophages with lymphocytes and many acid-fast rods. And of course, you can do culture or PCR to identify those if the histology was not satisfactory. Uh, Leprosy, clinically, it will appear as a well circumscribed hypopigmented area, and this is unique because, like on histology, it looks like sarcoidosis, like naked granuloma. However, the unique feature of those granulomas are the nerve involvement. So you will see perineural epithelioid granuloma, and usually it affects the hair follicle or like the adnexal structure with many lymphocytes and macrophages. So, leprosy is obligated intracellular bacterium. Usually, it causes well organized epithelioid granulomas around the nerves, and usually, necrosis is very rare. You can order fight staining to identify those because acid fast usually is false negative. PCR is the superior for identifying those uh, organisms. Fish tank granuloma, we see it on the upper extremity as erythematous or villous, scaly, verrucous plaques with scaling formation that follow the lymphatic vessels. If you look on histology, they form granulomas that they look on high power if you're lucky to find organisms with Ziehl-Neelson staining. So it is a typical mycobacteria that caused by Mucobacteria marinium, and the name reminds us of the marine, and that's why those lesions, the clinical history is suggestive. If somebody works in fresh or salt water in a fish market or something of sort of, usually we think of those Mycobacterium marinum. And in the acute stage, usually we will see neutrophils in the corneal layer that will reminds us of the suppurative dermatitis that maybe we'll think about like fungal infection. However, the granuloma formation with macrophages, rich infiltrate will kind of like help us to think about this diagnosis, in addition, of course, to the clinical history. PCR is recommended, especially for those mycobacteria, because it's hard to identify those on histology. Uh, Fungal infection is one of those unique features clinically that sometimes they appear on the skin as mass formation. And we had a case last week, a very massive lesion that the surgeon thought about excising those because he thought about tumor, and thankfully he did a biopsy which came to our lab, and we were able to identify those hyphae formation on H&E. And this is usually will take long time, up to a year of treatment systematically to help those patients. So we finished the infectious category, and now we move on to the non-infectious category, and those we divide them into also two subcategories: the ones that happen with the connective tissue degeneration, and those are granuloma annulare and necrobiosis lipidica. So granuloma annulare is clinically it appears as annular rash, and if you look on histology, we have degenerative connective tissue surrounded by elongated palisading epithelioid cells. And if you are suspecting those like areas to have like this kind of pale pink deposition, you can order Alcian blue or iron staining to look for mucin deposition in order for you to diagnose this granuloma annulare as a dermal, well circumscribed lesion. So these lesions, as we said, mucin is increased in the areas of connective tissue degeneration, and is important to differentiate granuloma annulare from epithelioid sarcoma because it looks like palisading type GA, but the necrotic area in the epithelioid sarcoma usually is surrounded by neoplastic cells. The other important differential diagnosis for those is the histiocytic granulomatous mycosis fungoides, and it looks similar to the interstitial type of GA, but usually MF has a typical T cell and usually has this monoclonal infiltrate, which you will see like CD4 to CD8 bias, and you will see other markers, immune cells, that will help you to think about MF. Necrobiosis lipidica, this is usually happens in association with diabetics, and because of enhanced glycosylation of dermal glycogen and increased collagen cross-linking. Rarely, there were some reports that these lesions transformed into squamous cell carcinoma. On histology, you will see microvascular changes and degenerative process, and this is called the red type sclerotic collagen that is happens because of the degeneration of the collagen. and it gives this wedding cake like appearance with alternating layers of degenerated sclerotic collagen and layers containing granulomatous infiltrates. And there is varying amounts of macrophages, epithelioid cells, and giant cells intermingled with lymphocytes and plasma cells. Necrobiotic xanthogranuloma is the first disease. So we finished the category that happens with degeneration of the collagen, and now we move on to the category that happens with systemic disorders. The first one is necrobiotic xanthogranuloma, and as for example in this case report from the British Journal of Dermatology, we see this patient has CMML, and clinically it would appear as a yellowish plaque with telangiectasia, happens especially around the eye and the neck and the upper extremities. Sometimes we see ulcerations, and uh, also other organs are involved like lungs, heart, intestines, and muscles. Uh, Paraproteinemia in disorders that have plasmacytoma or lymphoproliferation. Uh, the, the disorder or the pathology will be the entire dermis and subcutis, where we see large areas of sclerotic degenerated collagen with macrophages, sometimes foamy, and giant cells, often the Teuton type, with cholesterol clefts. Interstitial granulomatous dermatitis. This happens because in association with autoimmune inflammation, and this we see like in rheumatoid arthritis, lupus, thyroiditis, but also with other malignant diseases. Clinically, some of them they give this clinical feature very unique, cord-like induration. They call them the railway track dermatitis. Sometimes also we see papules, plaques located on trunks and proximal extremities. Usually it is dermal component without epidermal involvement, and we see interstitial infiltrate composed of macrophages, lymphocytes, and neutrophils, and we see the floating signs, which are the collagen fibers that are surrounded by those infiltrates. Rheumatoid nodules is happens also because of immune complex deposition of rheumatoid factor following minor trauma. We see areas of degenerated collagen with large amount of fibrin that it is positive for PAS, and nuclear dust surrounded by elongated macrophages and giant cells in palisading fashion. If you look into this lesion, it also looks similar to granuloma annulare, and sometimes it's hard to differentiate between the two, especially if the Alcian blue in granuloma annulare did not stain well those lesions. So you have to rely also on the clinical history to differentiate. So you have like two lines you can order for those Alcian blue. So if mucin deposition is increased, you suspect that this is more like GA type. If the mucin deposition is not increased, and also the clinical history is near the joints in rheumatoid arthritis patient, you suspect this is rheumatoid nodule. Gout happens because of urate crystal deposits, and usually we see on histology those like cloud-like features, and you see also giant cells and macrophages, palisading granulomas, and when you do polarized microscopy, you can detect those refractive properties of the needle-shaped crystals. One important note you have to keep in mind is when you send those biopsies, don't put them in formalin, because formalin will destroy the crystals. Instead, you have to send them to the lab with um, uh, uh, alcohol instead of formalin. Orofacial granulomatosis with Crohn's disease. This is happen in association with Crohn's disease. We see, as the name implies, oral lesions, and also Crohn's disease will help us to identify those lesions. On the skin, they appear as sarcoid granulomas, naked granulomas with giant cell formation and histiocytes with not many lymphocytes surrounding them. And also, like, the clinical history will be helpful. Sarcoidosis, as we mentioned earlier, happens in the dermal area. The epidermis is unchanged, and those granulomas, as we said earlier, those are naked granulomas. They are formed of histiocytes and not many lymphocytes around them. Sometimes we see asteroid bodies. Those are like collagen degeneration. They look like star-like formation, or sometimes we see those calcification inside the macrophages that they are called Schumann bodies. So we finish the chapter, and let's see some examples under the microscope. And I want to acknowledge Path Presenter, an awesome website for teaching and for presentations. Very good. Like they have like tons of cases you can see on each pathology. So I encourage you to go and sign up for those for this website and learn more. So let's see like some examples from the collection of path presenters. So we see this lesion. We don't have the upper part. We don't have the epidermis. So we are unable to see like if there is any changes. But we have the subcutaneous and big part of the soft tissue part. And we see like these areas of uh, granuloma formation surrounded by fat, which appears to be a lot of collagen deposition, and we have dilated vessels. So if we go on higher power to try to identify those granulomas, we start seeing a lot of inflammatory cells that forming like germinal centers or collection of lymphocytes with lots of uh, fat around them and dilated vessels. And if you choose this area and go on high power, you start seeing a lot of central necrosis in this area and granuloma formation. And if we look, we see giant cells. These all multinucleated giant cells that even forming a horseshoe pattern of Langerhans giant cells. Florid examples, very nice example of TB granuloma. So the key features are the necrosis, the granuloma formation that is surrounded by lots of inflammatory cells, and we have the giant cells. They look like horseshoe like pattern or Langerhans giant cell granuloma. So moving on, we have this example. So we have this big biopsy from the skin where you see the epidermal area is intact. However, we have in the dermis, we have all these granuloma formation filling the entire dermis. So if we go on high power, they are involving the adnexal unit. We try to go on high power, try to identify those granuloma. So you see all these structures are nerve structures. All these, this is like cut in kind of perpendicular on the nerve, and you see all these nuclei of the nerve structure, and you see all these granuloma surrounding the nerves. So this is a nice example of leprosy. Of course, this is suggestive like of leprosy, although you need to do further workup to find the organism. However, very nice example of leprosy where you see the granuloma. They are naked granuloma like the sarcoid granuloma with not a lot of lymphocytes around those. But these granulomas are surrounding the nerve structure. So we move on to another example. This is a punch biopsy, and as you see, also the epidermis appear okay, not involved. However, if you look, the entire dermis is involved with this uh, infiltrate of inflammatory cells that even reaching out the subcutaneous area with the fat. And if you look on high power, into those collagen area, you see that those collagen bundles, they appear necrotic. So we call this necrobiosis. And if you look into the main pattern, it appears like the inflammatory cells are alternating on low power with the necrobiosis. So we call this necrobiosis lipodica. And of course, you have to do further correlation with the clinical history. And also you can do also like Alshem blue to rule out any other etiologies. But I think for the most part, most pathologists will feel comfortable if the clinical history is suggestive to sign out this case as necrobiosis lipedica. In this case, it happened to be in addition or in association with a diabetic individual. So moving on, we have this punch biopsy of this very unhealthy skin where you see the epidermis. It looks a little bit has epitheliomatous hyperplasia, especially here, where you see the epidermis is going in fashion that is infiltrative into the dermis in epitheliomatous hyperplasia fashion. So if you look into the dermis, it looks infiltrative or invaded by lots of inflammatory cells. So if we go on high power, trying to identify the pattern, we can say that there is granuloma formation, especially here in this area. There is, and here there are some granuloma formation. However, it's not well defined granuloma. But if we go on high power, we see those organisms inside the macrophages. So what are these organisms? We have also giant cell formation and lots of all these neutrophils. It's like abscess formation. If we look for another area, so this is a giant cell, multinucleated giant cells, and we have this organism inside those giant cells. So this is paracoccoidemycosis. This is a special type of fungal infection. Very beautiful example uh, on this lesion where the organism is clear with this like black discoloration inside the macrophages in suppurative type of granulomas. So this is when you look on low power, you see like those infiltrative granulomas with uh, neutrophils. And if you go on high power, you try to look for a specific examples, you will be able to identify this lesion is a florid example. However, you have to do further like testing, but I think on H&E is very clear. Like look at all these organisms here more and more, and we have here more. So very beautiful example of paracoccoidemycosis. Moving on, we have this punch biopsy. you see the epidermis. It looks for the most part okay. However, we have those granuloma formation that involve the entire dermis and also involves the adnexal structure. If we go on high power, so all these granuloma formation, they look with minimal inflammatory cells around them. They look naked for the most part. We have here giant cell, multinucleated giant cells, and we have histiocytes trying to look for more examples, more of these naked granuloma. And if you look on high power, you can see asteroid bodies. So this is a nice example more here, asteroid bodies. So this is a nice example of sarcoidosis. Very, very nice example where you see multinucleated giant cells, naked granulomas with not many lymphocytes around them. Beautiful example, sarcoidosis. Moving on, we have this punch biopsy. And if you look into the epidermis, it looks okay for the most part. But we have this dermal lesion that appears well circumscribed, involving the lateral margin, not the deep margin. So if we go on high power, you see all these histiocytes with this degenerated collagen. And if you try to identify also, you can see some giant cell formation like this one here, multinucleated giant cells with lots of mucin deposition, especially surrounding or surrounding these areas. So palisaded type of granuloma. This is very nice example of granuloma annulare. If you are not sure, you can do Alcian blue. It will highlight the mucin deposition, and very, very nice example, granuloma annulare. Moving on, we have this punch biopsy, just to compare with the granuloma annulare we saw. So we have this punch biopsy, and the epidermis appears okay for the most part. However, we have something in the dermal area, and if you look on this power, you see like there is a lot of inflammatory cells infiltrate in the dermal area with necrobiosis of the collagen. So if I tell you that this patient has acute myeloid leukemia, what would be your diagnosis? So this is basically a necrobiotic granuloma that happens with systemic disease. So this is necrobiotic xanthogranuloma. And we see those necrobiotic collagen bundles. Moving on, another example, we have these polypoid lesions that the epidermis will take one of them and will try to magnify. So the epidermis for the most part appears okay. And the dermis is involved with these histiocyte and giant cells. And in between those histiocytes and giant cells, we have necrotic or degenerated collagen. So this is juvenile xanthogranuloma. So they are forming granuloma in the dermal area with foamy histiocytes like these pale pinkish cells, and we have here giant cell formation, little bit of lymphocytes, and we have the degenerated collagen. You have more giant cells and all these foamy histiocytes, xanthogranulomas. Moving on, this is a very big excision, and we'll take just one piece. This is the middle piece. So if we go on high power, you will see like the epidermis appears okay for the most part, and we have these granuloma formation in the dermal area. So if we try to magnify those granuloma, we start seeing the histiocytes formation, and we start seeing this pigment, black pigment around those or inside those macrophages. We have more here and more here. So as you see, most commonly those pigment is in the superficial dermal area. So I'm sure a lot of you are shouting now the diagnosis. So this is granulomatous tattoo reaction, and I'm just showing you this to show you like the foreign body type reaction granuloma, which I'm sure like many of you are familiar with. And you see like here the giant cell type reaction formation, very, very florid example of tattoo formation. So all these granuloma formation, and you can see like in these areas in the superficial dermis, the tattoo, black ink, but the reaction pattern is very florid, where you see like the granuloma formation with histiocytes, giant cells, and inflammatory cells. And giant cell, that happens because of foreign body. Usually it looks like, sometimes they describe it as a chocolate cookie like pattern, where the nuclei, they appear in disorganized fashion, unlike the Langhans type giant cell. A final example we see is the sponge biopsy from an acral skin. You can tell because of the epidermis, it looks has a very thick corneal layer, and we see that in the dermis we have this lesion that occupying the entire dermis. And if we go on high power, you start seeing there is a palisaded area of lymphocytes that is surrounding this necrosis of collagen. So if you go on high power, all this necrobiotic collagen is surrounded by this palisading area of lymphocytes. So if I tell you that this patient has rheumatoid arthritis, I'm sure many of you will know the diagnosis, rheumatoid nodule. Uh, very, very nice example. Thank you for watching those videos, and please let me know if you have any questions on Twitter or by commenting on these videos.